I am your psychiatry faculty, Dr. Dharmendra Singh. So we'll discuss in, as you know, the name of our series. It's a INI-CET short series. As the name suggests, dear students, we'll try to give our the short that if any question will come from psychiatry, we'll try to touch it. It's not about boasting, but in before NEET PG also we discussed, and the all questions came from the what we have discussed in psychiatry. And it's not very difficult to do that, because in Indian exam it's a rule of our exams that they don't change the topic, they change the MCQs. So if you know the hot topics, if you know from where they are going to ask, you have a good concept of the subject, it's not very difficult to guess. So are you ready? Shall we start? If you have any query, please in between try to ask, so I will try to give the answer in between. Okay, so the question number 1, a 30-year-old male was diagnosed to have a schizophrenia. He was started on oral risperidone. He came back to the emergency department in a few hours with a complaint of uprolling of eyeballs after taking this antipsychotic. Which among the following would be the next step in the management of this patient? So basically, patient is a known case of what? Schizophrenia. We started one antipsychotic, the name is what? Risperidone. So what happened? Uprolling of eyeballs. So probably a side effect of a medication. So in this case, basically, every time in psychiatry, the psychopharmacology, they target the either antidepressant, antipsychotic, the drugs for the dementia, the child psychiatry. So 2 to 3 questions they are asking from this area. It's a very important area. Antipsychotic, what are the antipsychotic? Typical one, atypical, depot preparations, and the side effects of these antipsychotics. In this MCQ, the side effect examiner try to hint that it's a acute dystonia. So basically, one of the side effect of acute dystonia, one of the side effect of antipsychotic is acute dystonia. As the name suggests, it's a acute. So always examiner will give you hint that this side effect occur within 2 weeks after starting medication. After starting antipsychotic, usually you have this side effect within 2 weeks. So in MCQ also we will see that it started after giving the the patient started on oral risperidone, he came back to the emergency, means it's soon, so within 2 weeks. In acute dystonia, we have the upper body part usually involved, the involuntary movements of neck, jaw, and facial muscles. So basically, uprolling of eyeballs, ocular muscles involved. In this, the treatment what we give, usually here the answer is given IV promethazine. Basically, usually we use the intramuscular Phenargan. Phenargan is a trade name. Basically, yes, it's a promethazine. We give, and patient get the immediate relief. Apart from it's a injectable. Apart from that, if in tablet form they ask, we give the tablet trihexyphenidyl or benzohexol. So trihexyphenidyl or benzohexol we give. Apart from acute dystonia, so in this MCQ the answer will be IV promethazine. The answer B for Bombay. I will open, so if you have any query I can. Okay, so trihexyl, and apart from these side effect, what other important side effect they can ask? One is we have akathisia. Akathisia. Akathisia is a also subjective feeling of restlessness. In akathisia, either they will describe the akathisia description, and then examiner will ask what's your answer or what's your diagnosis akathisia, or they will ask that what first step you'll do. The first step in akathisia, what you do, you decrease the dose of antipsychotic. You decrease the dose of, so patient is on one antipsychotic. If the patient develop the akathisia, we try to decrease the dose of antipsychotic, and still if patient not improving with the side effect, then what we'll do, if they ask the drug of choice, then your answer will be beta blocker. So there are 3 MCQ they can ask. One is that description, and then they ask what's your diagnosis akathisia. Second, what the first step. Please be careful, if they ask the first step and if the option is given decrease the dose of antipsychotic, then go for it. If they ask the drug of choice, then you have to go for propranolol or beta blocker. Okay. Apart from that, we have extrapyramidal side effects. Another side effect is what? Extrapyramidal side effect or Parkinsonian symptoms. Parkinsonian side effect. Basically, what is Parkinsonian disease? The Parkinson disease is what? Decrease the level of dopamine deficiency. Basically, by giving the antipsychotic, what we are doing? We are creating an artificial picture of Parkinson disease. So the Parkinson disease we have, where we have what? Tremor, we have rigidity, we have hypo or bradykinesia. Same the side effect with the antipsychotic, we have these features. Along with that, there is also salivation. And the Parkinson disease we treat with the dopamine agonist, levodopa, carbidopa, selegiline, but the antipsychotic induced Parkinsonian side effect or the extrapyramidal side effect we treat with the as I mentioned, the acute dystonia, we treat with the trihexyphenidyl and benchexol. Okay. Side effect I am going just little thoroughly, because it's a important area where the examiner target again and again. Neuroleptic malignant syndrome, they can ask high grade fever. Patient will have high grade fever, patient will have rigidity, and patient hemodynamic instability. If you will check the CPK, creatine phosphokinase, it will be more than 1000. You are very clear cut, you are very clear that okay, this is a diagnosis of what? NMS. If they ask that drug of choice in NMS also, here also be very careful, like in akathisia I was telling you. They can give you a description of neuroleptic malignant syndrome. They can ask you neuroleptic malignant syndrome. Apart from that, they can give you the description of neuroleptic malignant syndrome. If examiner is asking you what's the first step, then your answer will be stop antipsychotic. So first step in neuroleptic malignant syndrome also stop antipsychotic. If they ask the drug of choice, then you have to go for what? IV dantrolene. Okay. And we have tardive dyskinesia. So in tardive dyskinesia, the acute dystonia, the upper body part is involved. In tardive dyskinesia, we have the lower body part also get involved. So in tardive dyskinesia, acute dystonia within 2 weeks. Tardive dyskinesia, we need at least 2 months exposure to the antipsychotic. Okay. Well, before we had only option that okay, you decrease the dose of antipsychotic, if patient is not improving, you convert the typical antipsychotic to the atypical antipsychotic. But currently we have FDA approved drug for tardive dyskinesia, valbenazine and tetrabenazine. This MCQ they can ask valbenazine and tetrabenazine. Okay. So these are the few side effects, the important one. Apart from that, we have a quetiapine. Quetiapine causes cataract. Chlorpromazine causes skin rash or photosensitivity. Okay. The cardiac side effect, we have arrhythmia. Arrhythmia means you can increase the QT interval. Okay. Ziprasidone is an atypical antipsychotic which is most notorious to increase the QT interval. Okay. And there is a postural hypotension. Apart from that, there is a hyperprolactinemia. Because of that, person will have the menstrual irregularities, infertility, gynecomastia, galactorrhea. These you know. The other important side effect is what? Metabolic syndrome. In metabolic syndrome, if they ask you, before we are talking about that this medication decreasing the weight, this medication increasing the weight, but now we are, rather than weight gain, we are talking about the metabolic syndrome, that this medication increase the metabolic syndrome, this drug is not. Why metabolic syndrome? Because in weight gain we are only targeting the one parameter weight, but in metabolic syndrome we are targeting the 6 parameter, and they are what? They are the, we have the blood sugar level. Okay, blood sugar level, we have HDL, we have triglyceride. Okay, we have blood pressure, we have body mass index, and we have waist circumference. So we are having a waist circumference. So we are having a 6 parameter. Out of this 6 parameter, a patient fulfilling the 3 criteria, then we say the person is suffering from metabolic syndrome. Among antipsychotic, clozapine is a most common cause of metabolic syndrome. Please remember, in NEET PG also they have asked, that they ask patient is on one drug, then a patient is started, so they have given the picture of treatment resistant schizophrenia, and that clozapine is a drug of choice of treatment resistant schizophrenia. And then but examiner mentioned that after starting clozapine, the patient started, he did not mention the clozapine, he mentioned the drug B. After starting drug B, the patient had a hypertriglyceridemia. So basically he talked about the metabolic syndrome, and then he asked that which is a drug B, and the answer was clozapine. So clozapine is the most common cause of metabolic syndrome. Apart from clozapine, the olanzapine is a second most common cause. It's the second most common. Okay, yeah. And the which antipsychotic? Aripiprazole and ziprasidone, they basically don't cause weight gain. You can say they are weight neutral antipsychotic. Or they don't cause metabolic syndrome. You can use one of these, whatever the examiner is asking. The basic, if you have a concept, then whatever the language he is using, you always can give the right answer. Okay, so this is a if you are asking any question, I am not able to see. Okay, yeah. Question number second. So any queries you have? Yeah, so very good evening. Abhishek, Karthik. Any query you have, please let me know. Okay. The question number second is, yeah, question number second is, so the question number one, the option is B, IV promethazine, IV or IM, whatever the answer they are giving in exam. A 40-year-old male who was a chronic alcoholic was diagnosed to have liver cirrhosis and he stopped taking alcohol suddenly. He came back to the OPD with withdrawal symptom. Which among the following is a among the following would be the preferred in this patient? So diazepam, alprazolam, clonazepam and lorazepam. So what will be the answer? So in this, basically the answer will be, see, whenever the patient come to us, patient having a alcohol dependence syndrome or alcohol dependence, in alcohol dependence basically, yeah, so answer will be metabolism. I was telling metabolism, yeah, a metabolic syndrome I was telling, Omit sir. It was a metabolic syndrome. In alcohol dependence, patient came to us, patient is fulfilling the criteria of alcohol dependence. We started treatment. In treatment, the first step of alcohol dependence, the first step is what? Detoxification. Detoxification, basically we do with what? We do with long acting benzodiazepine. We do with long acting benzodiazepine. Long acting, they have a long half life, they cover the withdrawal symptom nicely. But issue is what? The long acting benzodiazepines like diazepam and chlordiazepoxide. We use them because they have a long half life, they cover the withdrawal symptom nicely, but they are contraindicated in liver disease. That, dear students, please remember, they are contraindicated in liver disease. And basically the lorazepam is we are not using usually because it has a short half-life, but it is not contraindicated in liver disease. So please remember, lorazepam we use in a two situation, either person is having a liver disease, then we go for the lorazepam because it is safe in liver disease, and number two, the liver function test is not available. So patient came to us, we are sitting in a setting where the LFT is not available or the person is having a liver disease. In these two cases, you go for the lorazepam. Lorazepam is a short acting, but it is not contraindicated in liver disease. In this MCQ, if you will see what they mentioned, that person is having a liver cirrhosis and person is yeah, so the patient is having a liver cirrhosis and patient came to us. So in this case, liver cirrhosis and he stopped taking alcohol suddenly. He came to the OPD with withdrawal symptom, and which among the following would be the preferred? So the in this answer will be D for daily lorazepam. So in this MCQ answer will be D for daily. This is a very important area. So few important point I will tell you. If they ask you the most common withdrawal symptom, the most common withdrawal symptom will be tremor. Okay, most common withdrawal symptom. Most common withdrawal syndrome will be hangover. We have simple withdrawal symptom, the simple withdrawal symptom, we will not go through it. We have a complicated withdrawal symptom. This complicated withdrawal symptom they are asking again and again. So, and it's a favorite MCQ of AIMS. Now we can say the INI-CET, but the AIMS PGI, the basically the AIMS MCQ, the question bank, if you'll see, they usually ask the complicated alcohol withdrawal symptoms. In complicated alcohol withdrawal symptom, first we have alcohol withdrawal seizure. Alcohol withdrawal seizure. Okay, 2 point about alcohol withdrawal seizure. The peak of alcohol withdrawal seizure is between 12 to 48 hours. 12 to 48 hours. Okay, peak. Person stop the alcohol between 12 to 48 hours, there will be high chance that person will have seizure. Number two, these seizure are in a continuum, 2 3 4 seizure at a time. So patient even can die. It's a dangerous situation. Second point about alcohol withdrawal seizure, you have to remember that if they ask you treatment of alcohol withdrawal seizure, IV diazepam, no anti-epileptic. You have to establish the history nicely. If patient is having a only alcohol withdrawal seizure, you ruled out that it's not a like independent epilepsy, then there is no requirement of anti-epileptic. You just terminate the seizure episode with the IV diazepam. Second, a complicated withdrawal symptom can be alcohol withdrawal delirium. Alcohol withdrawal delirium. In alcohol withdrawal delirium, what they can ask, another name of alcohol withdrawal delirium is what? Delirium tremens. The peak of alcohol withdrawal delirium is between 2 to 5 days, maximum up to 7 days, maximum up to 7 days. So please remember, the alcohol withdrawal delirium, the peak is 2 to 5 days, maximum up to 7 days. All delirium benzodiazepines are contraindicated except alcohol withdrawal delirium and benzodiazepine withdrawal delirium. So if they ask you the drug of choice in alcohol withdrawal delirium, they are the long acting benzodiazepine like diazepam. So again I am repeating, all the delirium, the main treatment of, otherwise if you'll talk about delirium, the main treatment of delirium is what? It's a treat the cause, treat the etiology. But in our alcohol withdrawal delirium, the long acting benzodiazepine is a treatment of the drug of choice, you can say. And the one MCQ here they can ask, see, one is we have alcohol withdrawal delirium. Okay, one we have alcohol withdrawal delirium, second we have, I'm just comparing because they are sometime Wernicke's encephalopathy, again and again they are asking. So Wernicke's encephalopathy we have due to what? Due to vitamin B1 deficiency, the thiamine deficiency. Okay, delirium can be a part of Wernicke's encephalopathy also. The mnemonic GOA. Okay, global confusion, delirium, ophthalmoplegia, and ataxia. Okay, in Wernicke's encephalopathy also we have delirium like global confusion. So how you will differentiate the alcohol withdrawal delirium and Wernicke's encephalopathy, because sometimes they can ask. So please listen carefully. If the examiner mentioned that it's an alcohol dependence patient, then he says that a person stopped suddenly alcohol, then you have to see the duration. If patient giving the history of delirium is what? Between what? 2 to 5 days, between 2 to 5 days, then it's a delirium. But examiner saying that person taking alcohol since 10 years, 15 years, so it's like he giving the hint that person is dependent. And then he says okay, the person is having a delay, he gives the delirium picture, but this delirium picture he is giving between 2 to 5 days, then alcohol withdrawal delirium. But he mentioned that person is fine till 10 days or 8th day, and after that he gives the picture of delirium, so then it's a Wernicke's encephalopathy. So just remember, alcohol withdrawal delirium will be before 7 days. If they give the history before 7 days of delirium and they associate with the alcohol, then it's always alcohol withdrawal delirium. If they give the history after 7 days and then they mention that the delirium picture is there, and they will mention other symptoms also of ophthalmoplegia or something, then the answer will be Wernicke's encephalopathy. So the first complicated withdrawal symptom is what? Alcohol withdrawal seizure. Second complicated withdrawal symptom is what? Alcohol withdrawal delirium. And the third complicated withdrawal symptom is what? Alcoholic hallucinosis. Alcoholic hallucinosis. In this patient will have what? Only will have what? Complaint of auditory hallucination. Patient will have only complaint of what? Auditory hallucination. Clear? Auditory hallucination. You have any queries, guys? Very good evening, dear. So auditory hallucination, no impairment of consciousness, No impairment of consciousness. No impairment of consciousness. So alcoholic auditory hallucination we can have in alcohol withdrawal delirium also, and auditory hallucination we can have in a alcoholic hallucinosis also. But in alcoholic hallucinosis we have auditory hallucination, but we don't have impairment of consciousness, but we have impairment of consciousness in delirium. Okay, so if you have any query in between, please let me know. Okay, so these are the complicated withdrawal symptom. So remember, alcoholic hallucinosis occur within 20, within 20 within 24 hours. Within 24 hours. Alcohol withdrawal seizure occur within the 12 to 48 hours, and the alcohol withdrawal delirium between 2 to 5 days, maximum up to 7 days. Okay, yeah. So in this, the second MCQ, our answer will be lorazepam. Our answer will be lorazepam. The third MCQ, the second will be answer D for Delhi. The third, a 30-year-old female came to the psychiatry outpatient department with the feature of hypomania. She had a past episode of mania also. Which among the following drugs needs to be avoided if the patient has plans to conceive soon? That's a very important MCQ. Basically, we have mood stabilizer. We have mood stabilizers which we are using in bipolar disorder. What all mood stabilizers we have, students? We have lithium, we have sodium valproate, we have carbamazepine, we have oxcarbazepine, and we have lamotrigine. 100% one MCQ they will ask from this area. Okay, lithium. What's the teratogenic side effect of lithium? We have Epstein anomaly. Okay, sodium valproate, neural tube defect. Okay, carbamazepine also neural tube defect. Lamotrigine is a safest mood stabilizer in pregnancy. Okay, it's a safest mood stabilizer in the pregnancy. Okay, so lamotrigine is the safest one. I'll just write and then further we'll discuss. So the safest is lamotrigine. If suppose lamotrigine is not in the option, oxcarbazepine. Okay, oxcarbazepine. If oxcarbazepine is not in option, then you go for the lithium. That's how you have to remember. You can't give the valproate. Even in MCQ, even you go through the pharma book, it's very clearly written, even you have to be very careful in a childbearing age, because if the patient is not literate, they will not have a planned pregnancy. She can have a side effect. So if the valproate is like a crime giving in the pregnancy, please remember. The first one, lamotrigine. If not in option, then ox. If not in option, then lithium. Why lithium? Lithium also causes the Epstein anomaly, but the data suggests the neural tube defect caused by the valproate and carbamazepine is far more than the Epstein anomaly caused by the lithium. So lithium is safer than your valproate and carbamazepine. Apart from that, lithium, important drug. They ask, read everything about lithium. Okay, the half-life of lithium is what? 1.3 days. That you have to remember. They ask the serum lithium level in acute phase is what? 0.6 to 1.2 millimole per liter. If they ask you prophylaxis, the 0.6 to 0.8 millimole per liter. 0.8 millimole per liter. It causes the what are the important side effects? It causes the hypothyroidism, it causes the nephrogenic diabetes insipidus. Okay, yeah, it causes the, it also depresses the sinus, okay, in our cardiac. So the thyroid profile, the renal function test, and the ECG you have to do before starting lithium. Some other important side effect, we have ataxia, we have a diarrhea, acne, psoriasis, okay, that you will read. Important one, when they ask that after starting lithium, when you have to check the uh, serum lithium level, because the lithium is one of the drug which has a narrow therapeutic index. So any medication which has a narrow therapeutic index, minor increasing the dose can cause toxicity. So if you will not check the level, it can cause toxicity. So any medication which has a narrow therapeutic index, you have to go for the level, you have to check the level. In lithium, when we check the level, it decided by the steady state level, okay. So according to the half-life, so always the after 4 to 5, what is the steady state level, that once any drug achieve the steady state level, then there is no fluctuation in the concentration of that drug. So and thereafter only we check the level of that drug, okay. So any medication achieve the steady state level only after 4 to 5 half-life. So if you want to check the level of serum lithium, when you will check, you will check after 4 to 5 days, particularly fifth day, okay. And when you will check, after 12 hours of last dose, 12 hours of last, okay. These MCQ frequently again and again they ask, so be very careful about it. So question number 3, answer will be valproate, you have to avoid. So answer is C for Calcutta. Question number 3, valproate. The following condition will be exclusively seen in the female: the selective mutism, Asperger syndrome, Rett syndrome, and autism. So dear students, answer will be Rett syndrome, okay. So I will little talk about the Rett syndrome. Any MCQs is okay. So you have any query? Yeah. Hello, hello, hello Rajput. Hello, very good evening everyone. Yeah, so what is Rett syndrome? See, we have nowadays, before we are calling autism, now we call it a autistic spectrum disorder. Autistic spectrum disorder. In autistic spectrum disorder, we have autism, we have Asperger's syndrome, and we have Rett's syndrome, we have Heller's syndrome. Heller's syndrome. Okay, Heller's syndrome. Rett syndrome, again and again they are asking, so we will briefly cover Rett syndrome. Yes, usually this line they are asking, it is almost but not exclusively, found in girls. So this MCQ, before they ask that all of the following are true regarding Rett syndrome, except, and that time they asked that it is exclusively found in girls, and now they asked, and that was the like option of exception, and that was a wrong answer. But now they, in this MCQ, it is given that exclusively yes, so it is almost, you can say almost exclusively found in girls. Okay, up to 5 months growth is normal. Up to 5 month growth is normal, and then there is a regression starts, okay. Up to 5 months growth is normal, and then there is a regression starts, correct? Yeah. In regression, what will happen? Person will have microcephaly, that they are asking. Head circumferences get decreased. Repetitive hand movements, the child girl will have repetitive hand movement. Okay, so her skills get impaired, repetitive hand movements, microcephaly. Okay, another roughly 75% girls, they develop the seizure in Rett syndrome. Okay, 75%. If they ask most common cause of death in Rett syndrome, your answer will be respiratory failure. Respiratory failure. Okay, yeah. But if they ask most common cause of sudden death, then your answer will be cardiac failure. Please remember. So you have to be, be very careful about the language in the exam. The most common cause of death, respiratory failure. Most common cause of sudden death, cardiac failure. Okay, there is a mutation in MECP2 gene that they are also asking in medicine patho. They will tell you, so mutation in MECP2 gene, we have Rett syndrome. It is almost exclusively in the girls in this, according to this MCQ, but I am telling you correctly, it is like not exclusively, it is almost exclusively in the girls. It in rare condition it can be found in boys also. In boys it is more lethal than in girls, but yeah, almost exclusively it is in the up to 5 months growth is normal, and then there is a regression starts. Okay, autism, autism, we are making a diagnosis of what, around by 3 years of age. We have three important symptom in autism. What we have: impairment in language and communication, we have an impairment in social interaction, and we have stereotype behavior. Corpus callosum is an important brain area involved in autism. Okay, yeah. And MCET, we have MCET. It's a modified chart for autism in toddlers. Modified chart for autism in toddlers. This is a screening test. This screening test we use to screen whether child is suffering from autism or not. Okay, yeah. And Asperger syndrome, just remember, Asperger syndrome also we use the name in Asperger syndrome, we also say it's a high functioning autism. Another name of Asperger syndrome is high functioning autism. Okay, why we say high functioning autism? Because the third language and communication criteria is not there. There is no language and cognitive deficit in Asperger syndrome. That's why we say, yeah. Okay, yeah. So there is no language and cognitive deficit in Asperger syndrome. That's why compared to autism, Asperger syndrome has a better prognosis. And in Heller syndrome, in Rett syndrome, we say up to 5 months growth is normal, then there is a regression. In Heller syndrome, we say up to 2 years growth is normal, and then there is a regression. Another name of Heller syndrome, we also call it a dementia infantilis. Dementia infantilis, another name of Heller's syndrome. Up to 2 years growth is normal, and then there is a regression. In Rett syndrome, up to 5 months growth is normal, then there is a regression. Okay, yeah. If you have any query, please ask me. Are we going okay? Okay. Next is the next MCQ is okay, and MCQ is, so the fourth answer is Rett syndrome. The next is the for smoking suggestion, which among the following drug will be the most effective? The answer will be nicotine patch, nicotine gum, bupropion, and varenicline. So if they ask you treatment of nicotine dependence, okay, so we use the NRT, nicotine replacement therapy. Okay, NRT, nicotine replacement therapy. Nicotine replacement therapy we have in a form of gums. Chewing gum we have, 2 milligram and 4 milligram. We have in the form of patch. Patch we have 7 milligram, 14 milligram and 21 milligram. Okay, we have inhaler and we have lozenges. We have lozenges. Basically, NRT doesn't come in a tablet form, that you have to remember. It doesn't come in a tablet form. And bupropion, we have antidepressant. The mechanism of bupropion is what? Norepinephrine dopamine reuptake inhibitor. It basically increase the dopamine level, and basically in reward pathway, any substance we take including nicotine, we increase the dopamine. So bupropion basically increase the dopamine level in the frontal lobe, and that's how basically it help in a smoking suggestion. But yes, varenicline is a most effective drug in nicotine dependence treatment. Okay, alpha 4 beta 2 partial agonist. Alpha 4 beta 2 partial agonist. Okay, remember, one of the side effect of varenicline is what we have. One of the side effect of varenicline is what we have: suicidal. Okay, we have suicidal. So one of the side effect of varenicline is suicidal idea. Although in MCQ they are asking, but yeah, usually in the clinical practice we don't see much, but they are usually asking. So it's a mechanism is alpha 4 beta 2 partial agonist. Okay. Okay, now we have, so in this MCQ, please remember the answer will be varenicline. In nicotine, it's one of the fastest addictive substance. In withdrawal symptom of nicotine, one MCQ they can ask, and that is what? Remember, bradycardia. Please remember, all substance withdrawal they have palpitation, tachycardia, except nicotine, which has bradycardia. At the varenicline, we have 3 months therapy of the varenicline. We start with the 0.5 milligram initial 3 days, 5 milligram morning evening, then we give 0.5 milligram 1 milligram for 4 days, and then we give 1 milligram rest 3 months. So it's a 3 months therapy, very effective medication. So the question number 5 answer will be D for daily. Question number 6, which among the following statement is correct about OCD? Atypical antipsychotic are the main pharmacological treatment. Do you think it's a main pharmacological treatment? No. So in OCD, obsessive compulsive disorder. Okay, the prevalence of OCD, the prevalence is 2 to 3%. That MCQ they are asking. Okay, corticostriatal, corticothalamic tract. Okay, like orbitofrontal cortex, then we have caudate nuclei, then we have what? Thalamus, and then we have again orbitofrontal cortex. This is a tract involved in a OCD. That MCQ, the new MCQ they can ask also. Orbitofrontal cortex, or caudate, thalamus, and then orbitofrontal cortex again. Okay. In obsession, if they ask you most common obsession, your answer will be contamination. If they ask you most common compulsion, OCD is also very important area. They are targeting again and again. Okay, that's why I'm just giving a little detail about the OCD. So yeah, most common compulsion, before it was a washer, now it's a checker. So that you have to remember. Before it was a washers, now it says checkers. Okay, that new MCQ you have to remember. Okay. Next is, yeah, contamination and checker. If they ask you the drug of choice is SSRI, particularly fluvoxamine, and if they ask you treatment of choice, then your answer will be what? ERP, exposure and response prevention therapy. Exposure and response prevention therapy is a treatment of choice. Drug of choice is what? Fluvoxamine. If they ask you the best modality of treatment, then your answer will be SSRI plus ERP. SSRI plus ERP. Sometimes they can give you SSRI plus CBT, whatever the option they give. So best combination is combination of therapy plus medication, and the treatment of choice is exposure and response prevention therapy. Drug of choice is what? Fluvoxamine. In exposure and response prevention therapy is also, please remember, the response prevention is more effective than response. So if they give the separate, that please remember, sometimes they give the separately also. So if they give the separate, response prevention is better than the exposure. So if you expose the person and if you not respond the prevents, then what will happen? Then patient will keep doing that act again and again. So response prevention is more important than exposure. Please remember the DBS, deep brain stimulation, is a FDA approved treatment in OCD. It's a FDA approved treatment in treatment resistant. So deep brain stimulation is one type of somatic therapy. It's FDA approved, we use in many other psychiatric conditions as well, but in treatment resistant OCD is a FDA approved treatment. We put the the electrode in the brain, and we along with our the battery, which we put under the chest muscles, and where sometimes they can ask where we put the electrode in DBS in OCD. Internal capsule. If they ask you MCQ in that depth, then you can answer. We have in mental state examination, you know that we have a various heading, and we describe various the symptoms in the various phenomenology in the psychiatry. Please remember, if they ask you obsession and compulsion, where you describe under what? Possession of thought. Possession of thought or thought possession. You describe under possession of thought what? Obsession. So you describe the obsession. You describe thought insertion, thought withdrawal, and thought broadcasting. So these are this thought phenomena. In first rank symptom we read it, and this thought insertion, withdrawal, broadcasting, and obsession. Please remember, it's a very important MCQ. We describe under possession of thought or thought possession. Okay, so this is about OCD. You have to remember. Please remember that OCD, before we were counting under the anxiety disorder. Now OCD we have in DSM-5 and in ICD-11 we have a separate category of OCD, and we call it obsessive compulsive and related disorder. Okay, dear students, so please remember that we have obsessive compulsive and related disorders. So now in DSM-5 and ICD-11 we separately describe the OCD, and under this obsessive compulsive and related disorder, what we have OCD, we have body dysmorphic disorder, we have hoarding disorder. Okay, we have olfactory reference syndrome. Okay, we have olfactory reference syndrome, and we have Psychotillomania and excoriation. Okay, yeah, this repetitive body pick, repetitive disorder we call them. So it's a trichotillomania, excoriation. So trichotillomania, you know, it's a hair pulling. Okay, repetitive hair pulling, and it's a repetitive what, skin picking, skin picking. Okay, olfactory reference syndrome. The in olfactory reference syndrome, person thinks that, you know, he is emitting some foul odor, उसके शरीर से कुछ बदबू आ रही है, you know, olfactory reference syndrome. The person thinks that person, that he or she emitting foul odor, foul odor from his or her body. Hoarding disorder, person is having a, in hoarding disorder, just remember one thing, that person is having a habit of collecting of unnecessary things or discarded thing, you know, he or she having a habit of collection. Hoarding disorder, the ERP is not useful in hoarding disorder. That's why they are asking one MCQ, that it has a poor prognosis. So if they ask that in obsessive compulsive and related disorder, which disorder has a poor prognosis, your answer, or worse prognosis, your answer will be hoarding disorder. Hoarding disorder. So these are the MCQs they can ask in OCD. So in this MCQ we were discussing that, okay, so we were, yeah. So which among the following correct about OCD? So atypical antipsychotic are the main pharmacological treatment? No, it is SSRI, fluoxamine. Before it was fluoxetine. The prevalence of OCD in general population will be 7 to 10%. No, it is 2 to 3%. Contamination is an uncommon obsession. No, contamination is the most common obsession. Okay, the option B is what, depression is a comorbid, you know, common comorbidity in OCD. Yes, person is having in OCD. See, person, you know that your hands are not dirty, but still you are having a thought that my hands are dirty, my hands are dirty, and you try to wash them again and again, and basically you are doing this against your will. You also have inside that I should not do this, but because these thoughts are coming and they are the anxiety provoking thoughts, and they are basically forcing you to do the act or do the compulsion. So you are doing this against your will. That's why person get frustrated, and ultimately OCD patient, you know, develops the depression. So what we call it a secondary depression. So that MCQ they are asking, that secondary depression seen in OCD. Okay, so before they ask the secondary depression, now this option is given, depression is common comorbidity. So you know, some or other things they are asking in such a way, but the topic is same. So OCD is another area, definitely some or other thing they are going to ask. Please remember one more important thing, pandas. Pandas is what? Pediatric autoimmune neuropsychiatric disorder associated with beta hemolytic streptococci. Okay, so it has been seen that the children who have, you know, the throat infection frequently during their childhood with the beta hemolytic streptococci, basically it's an autoimmune hypothesis. We have autoimmune response to basal ganglia, and because of this autoimmune response to basal ganglia, these children are more vulnerable to develop the OCD. So these pandas also they are asking. Okay, so these MCQ they can ask. So question number 6 answer will be you know, the B for Bombay, depression. Question number 7, we'll talk about question number 7. Just go, yeah, first we'll talk about question number 8. In which among the following condition risperidone is not used off label? Okay, so OCD, bipolar disorder, PTSD and dementia. So anybody can give the answer. Basically we have, you know, that OCD we use the risperidone. risperidone has, the low dose of risperidone we use in the OCD. In the OCD, it has 0.5 milligram, 1 milligram. It has role. In bipolar disorder, yes, it's antipsychotic. It has role. In dementia, also person is having a. In dementia, one thing we say, the behavioral and psychiatric, symptoms in dementia. Okay, BPSD we use the word behavioral and psychiatric symptoms in the dementia. That delusions and hallucinations, roughly like 20-25% patient of dementia, they develop the delusions and hallucination psychotic symptoms. So risperidone we can use there. Although we have a better choice nowadays, we use quetiapine, we use aripiprazole because they give the less side effect. But yes, from MCQ point of view, you can say that risperidone can be used, but in PTSD we don't use, risperidone. We don't use PTSD, post-traumatic stress disorder. It's a, like neurotic disorder. We don't have any role of risperidone in PTSD. So question number 8, answer will be C, PTSD, no role. Question number 9, we have 30-year-old female having repetitive thoughts of dirt, contamination, and there was repetitive hand washing. The following modality need to be, considered as the therapy of choice in this patient. So patient having what, as I mentioned, dirt, contamination, and repetitive hand washing. So basically contamination is there and hand washing is there. So it's a OCD. So cognitive behavior therapy, dialectical behavior therapy, systemic desensitization, exposure and response prevention. So the better answer will be question number 9. We will have what, D for daily, exposure and response prevention therapy. So again, that's why I mentioned that again and again they are asking the MCQ about the OCD. Dialectical behavior therapy we use in a borderline personality disorder. Borderline personality disorder, we use dialectical behavior therapy. Okay, so systemic desensitization, basically briefly I will tell you. Systemic desensitization, basically it is what, it is most commonly used behavior therapy, the most commonly used behavior therapy. And we use systemic desensitization. First we use what, the relaxation exercise. Then the second is what, we have imagination. The third we have what, artificial object. The fourth we have live object. So there are 4 steps of systemic desensitization. Initially we teach the patient relaxation exercise. Then we, suppose person having a phobia of lizard, छिपकली से किसी को डर लगता है ना, in girls it's very common. So the second step you do the, you ask the patient to imagine about the lizard, and it will also give her or him the anxiety symptom. After a few sessions she will be okay with the imagination. Then you bring the artificial lizard, you do the session, and then you do the with the live object. So this is the systemic desensitization, most commonly used behavior therapy. That briefly here I will just mention one point once we are discussing about it. Graded exposure is another behavior therapy. What's the difference between systemic desensitization and graded exposure? In the relaxation exercise is not a part of graded, so in graded exposure we have 3 steps only. What, imagination, artificial and live object. And in a systemic desensitization we have what, four steps. Okay, question number 9, answer is D for daily. Question number 10, on the base of ICD-11, the following body focused repetitive disorder has been included under obsessive compulsive or related disorder. Already I mentioned it is what, it is trichotillomania. So I mentioned here that body this trichotillomania and excoriation. This is what, body focused repetitive behavior or repetitive. So we have 5 disorder under obsessive compulsive and related disorder. One is what, OCD. Second is hoarding disorder. Third is body dysmorphic disorder. Body dysmorphic, I mentioned that body dysmorphic, what, person start thinking that some body parts look ugly. Sir, मेरा नाक टेढ़ा है, मेरा कान टेढ़ा है, मैं सुंदर नहीं लगती हूँ. And you know, this is the body dysmorphic disorder. Hoarding disorder I mentioned, trichotillomania and excoriation, skin picking, repetitive and the repetitive hair pulling comes under body focused repetitive disorder. These are the 5 disorder we have under obsessive compulsive and related disorder. Before we were that describing it is under the anxiety disorder, but now in ICD-11 and DSM-5 we have a separate this category and we describe separate. Okay, yeah. So in this question number 10, the answer will be B for Bombay. Question number 10. So students, are you getting point? Any queries you have? Yeah, trichotillomania. Very good, very good. Bagwal, yes, phobia. Very true. Any queries you have? Are we going okay? Things are understandable? In graded exposure, we have systemic desensitization. What one more therapy we have? If anybody can answer? Yes. Behavior therapy, flooding, direct exposure to live object, okay, yeah, direct exposure to the live object. Okay, nowadays we don't do flooding because it's very dangerous for the patient can have, can develop some issues due to sudden increase of anxiety. So nowadays we don't prefer it. Okay, now so this is the question number 10. Answer will be trichotillomania. B. 11. A 32-year-old male the lost his job 1 week back and he became irritable with the sad mood. His mood was worsened by the thoughts of the future and he was irritated towards his family members. Sometimes he went for a movie along with friend. During the movie he enjoyed it, but he had similar symptoms again when he returned back to his home. What would be the most probable diagnosis? So see, a 32-year-old male, he lost the job 1 week before. Okay, that's the 1 point. Second, person having a irritability, person having sadness of mood, and mood get worsened by the thought that what he's going to do. So that gives him stress about his his instability of the career, gives the stress to him. But and he's very irritable towards the family member. But when he goes to the movie with the friends, he enjoying it. So symptoms are not very severe, symptoms are intermittent, and it is related to one stressor particularly. So what will be the answer? Basically we have one adjustment disorder. That also please remember, we before adjustment disorder we were counting under the mood disorder, but now in DSM-5 we have separate category. What? Trauma and stress related disorder. In trauma and stress related disorder we have PTSD, post traumatic stress disorder. We have acute stress disorder, and we have adjustment disorder. So previously we were counting it under the mood disorder, and now we count it under the trauma and stress related disorder. Okay, so that's the question number, the important aspect of it. Adjustment disorder, basically when we make a diagnosis of adjustment disorder, we're making a diagnosis of adjustment disorder when person is having a history of either serious illness in close person, okay, in a loved one, serious illness, history of like the person having the losing jobs, okay, so some the migration, okay, so some any stressor person is not able to handle that stress and person develop the depressive symptom. So second point will be depressive symptom. Usually, please remember, this depressive symptom should develop within, usually within 3 months after stress. After stress. Suppose today person lost the job and after 6 months or 7 months or 8 months he developed the depression, then it is not adjustment disorder, it is independent depression. So to call it adjustment disorder, first history either given of serious illness in the person, in the family member, like mother suffering from cancer, person came to know today, that's how examiner will start the MCQ. Or there is the history of some losing job, some the immigration, some breakup in the relationship, which is usual nowadays. So in these type of any stressor will be given in the MCQ, examiner will start with this stressor, then he will mention some depressive symptom, but these depressive symptoms are not severe enough to make a diagnosis of depression. And this, the third important correlation, that symptom will develop as the examiner mentioned here, that after 1 week after losing job, so within 3 months after happening this stressor. Okay, so there are 3 points. One is stressor, second the depressive symptom but not severe enough, and the third the development of this symptom within 3 months after this onset of this stressor. Okay, even sometimes suppose stressor is also given, the duration is also within 3 months is given, but symptom severity is so high that you can make a diagnosis of depression, still I will advise you go for the depression rather than adjustment disorder. So it's a very tricky MCQ. It appear very easy, but you have to see the language, that what is the duration is given, whether the examiner is starting with the stressor or not, and the third important thing, the severity of the symptom. Severity of symptom should not be very high in adjustment disorder, they are very less severe. Okay, so this is generalized anxiety disorder, can't be the answer here. So here the answer will be in the question number 11, the answer will be A. Okay, generalized anxiety disorder, we have basically what, excessive worry. The patient will have excessive worry, but patient is not able to control that worry. Okay, not able to control that worry, not able to control, and person will have what, sleep disturbance, person will have fatigability, person will have irritability. Okay, person will have decreased concentration. Okay, so the sleep disturbance, fatigability, irritability, decreased concentration, the muscle tension. Okay, these type of symptom we have in a generalized anxiety disorder. Free floating anxiety, examiner can use the word. Okay, PTSD, post traumatic stress disorder. The first criteria of post traumatic stress disorder is what, basically person will have any event of catastrophic nature. The examiner will start the MCQ with the event of catastrophic nature. See, one is we have stressful event. Stressful event can be stressful for one person but not for the other person. But that that by definition, catastrophic event is an event which causes stress in everyone, almost everyone. For example, earthquake. Can you enjoy the earthquake, tsunami, the flood, the sexual assault, rape, major accident? These are the examples of catastrophic event, that event which causes stress in almost everyone. So the first, the criteria of PTSD is event of catastrophic nature. Then the person will have what, the flashbacks of those events. Person will have flashback of those events in the dreams and thought, and person will have what, hyper arousal symptoms, hyper arousal anxiety symptoms, and person will have avoidance behavior. Okay, suppose person had a major accident on a particular road, in future he will avoid that road forever. Okay, so this is the event of catastrophic event. First criteria, person will have flashback of those events in the thoughts and dream, person will have hyper arousal anxiety symptom, and person will have avoidance behavior. Usually we are making a diagnosis of PTSD within 6 months. If we are making after 6 months, then please remember we call it a PTSD with delayed onset. That MCQ they are asking. So if we are making the PTSD diagnosis after 6 months, then we call it a PTSD with delayed onset. Delayed onset. Okay. Within 1 month, within 1 month, if we are making a diagnosis of PTSD, we call it a acute stress disorder. Okay, we call it a acute stress disorder. And after 1 month we convert it into the PTSD. So be very careful if they give the description of PTSD, but the examiner mentioning after 2 weeks, 3 weeks, then and they mention both PTSD also and acute stress disorder also in the MCQ. Please go for the acute stress disorder. Okay, and in ICD 11, first time we have used the one term, what? Complex PTSD. That you have to remember. Complex PTSD, basically patient having a repetitive traumatic event like slavery, like sexual or physical abuse, repetitive, and that because of that person having a emotional numbing, he doesn't feel the emotions, depressive symptoms are there, we call it a complex PTSD. So first time that in ICD 11 we have used the term complex PTSD. Okay, EMDR, eye movement desensitization and reprocessing. Eye movement desensitization and reprocessing is a basically therapy we use in PTSD. Please remember, over the year it has been seen that it is not a good therapy. It is not a good therapy. So if they ask you the treatment of choice in PTSD, CBT, cognitive behavior therapy. Cognitive behavior therapy. Okay, what are the other disorder where we use the CBT? We use in depression. Okay, we use in a eating disorder. Okay, we use here in PTSD, and we use in a anxiety disorder. So anxiety disorder, eating disorder, depression, PTSD. Phobias, we use what? Behavior therapy. Okay, mixed anxiety depressive disorder, this is also a new term. Please remember about mixed anxiety depressive disorder, the option fourth, D option. Basically this is also new term in a DSM-5. basically sometime what happens, neither we are able to fulfill the criteria of depression, nor we are able to fulfill the criteria of anxiety disorder. In that condition, basically we make a diagnosis of what? Mixed anxiety depression disorder. Okay, so डिप्रेशन का क्राइटेरिया भी फुलफिल नहीं हो रहा, एंजाइटी का क्राइटेरिया भी फुलफिल नहीं हो रहा, वी गो फॉर द मिक्स एंजाइटी डिप्रेसिव डिसऑर्डर. सो क्वेश्चन नंबर 11 आंसर विल बी A for apple. Okay, question number 12, clear? A patient who was diagnosed to have a severe depression was treated with TCA, and there was significant improvement after 4 weeks. At the time of discharging the patient, what would be the most important concern? Regular monitoring of ECG for arrhythmias? No. Modafinil to counter the sedative effect? No. Therapeutic drug monitoring of TCA? Of course we don't do in these cases. Risk of suicide by TCA? Yes. Please remember, this is a very important MCQ, guys, very important concept. Basically again and again they are asking. So what's the important? Yeah, somebody is asking. Yeah, less than 1 month, more than 1 month PTSD. Very true. Hyperarousal, intrusive avoidance seen in PTSD. Yes, very true. Bhagavi, yeah, correct. Okay, so in this, basically about suicide they are asking many questions. Suicide, basically we have around 10.3 per lakh. We have the data. We have decreased level of 5-hydroxyindole acetic acid in cerebrospinal fluid in 10 point basically 6. Yeah, decreased level of 5-hydroxyindole acetic acid in the cerebrospinal fluid. Basically, when person is suicidal, we have grade of suicide. We have a grade 1. In grade 1, person will have, you know, death, you know, person will have wish to die, wish to die. Okay, wishes that Bhagwan mujhe utha le, wish to die, The grade 2, we have, the person having a death wishes, death wishes. Okay, kash mein, mar jata. And then we have grade 3, we have like intent to die, intent to die. Okay, intent to die. Thank you, thank you. Yes, very true, Bhagavi. Paradoxical suicide. Yeah, thank you. uh, yeah, intent to die. So okay, so intent is very important. We have to see, we have to see that's very true what she mentioned, that the paradoxical suicide, basically what happens initially when we have a like person having a depressive symptom, that time person can attempt suicide. Once the severity goes high, the normal person will think that in severity the suicide chance are more. Not, dear friends. Why? Because basically when the person having a severe depressive symptom, that time maybe person having a suicidal idea, but he doesn't have that much energy to act on it, because for suicide you have to make a plan, you have to act on this. So that time person may be having a suicidal idea, but person is not able to act on it. One, after starting antidepressant, after starting treatment, what happens, the gradually symptoms will subside, but that time ideas is still there, and suicidal ideas are there, and person can act. So be very careful. After discharge, you have to be on a regular follow-up with the patient. The follow-up should be with the short duration, because that time a very high chance of suicide, the suicidal attempt, or commit, a person can commit suicide. The indirectly examiner asked in this MCQ about the TCA. Why indirectly? Because see, basically that was a question mark on TCA, that the TCA, the 2 gram TCA person taking at a time, person can die. You as a maybe you are best psychiatrist in the world, but you can't predict the suicide. So basically that was a question mark over the TCA, that how you can give the prescribe the drug to the patient which is lethal in overdose. So TCA can cause toxicity. TCA can toxicity. What happens in TCA toxicity? Briefly, because this MCQ they can ask. In TCA toxicity, what we have? Right axis deviation, right axis deviation. Okay, increase QT QRS interval. QRS interval is more than 100 millisecond. Okay, yeah. And a person will have AV block. What is the treatment of TCA toxicity? As you know, the IV sodium bicarbonate. Gastric lavage, initially we can use immediately if the patient rush to the, somebody can take him to the casualty. That time gastric lavage is important, is in immediate, otherwise no, otherwise. Okay, so in this MCQ be very careful that yeah, treatment or TCS initially with, very true, it's a sodium bicarbonate. Very true, very nice. Okay, what are the reason of suicide? If the person has a past history of suicide, past history of suicide, there is a family history of suicide. In our society, everything they are asking, not even when go for the marriage or something, always they ask the whether in these families the suicide was there or not. So our the elderly people, maybe they did not have a very good knowledge of science or something, but these all things are based on science. Yeah, so family history of suicide, person is having, yeah, if the person is alone, like single, or person is divorcee, divorced person, if the age is more than 45 years. Okay, the person is suffering from chronic illness. These are the predictor of suicide. Okay, what are the psychiatric disorder where the suicide is more common? Depression is the most common cause of suicide in psychiatric disorder. Please remember, Most common cause of suicide in is depression. Apart from that, yes, in schizophrenia we have suicide, the bipolar disorder, substance use disorder, okay, and personality disorder, particularly borderline personality, borderline antisocial. These are the correct, Bhagavi? Okay. Another is the next MCQ is, so the in this MCQ we discussed the question number 12, answer is B for Bombay. Question number 12, answer is B for Bombay. Question number 13, in a patient with Alzheimer disease, delirium can be differentiated from dementia is. So please remember that we have a delirium, have a dementia. In the delirium is the onset is acute in delirium, onset is gradual in dementia. The consciousness is impaired. The cardinal feature of delirium is what? Impairment of consciousness. Impairment of consciousness. In dementia, basically it is, intact. Please remember, although dementia is a organic disorder, but in dementia, basically the till last moment, unless the delirium is superimposed on dementia, in dementia the person is clearly conscious. Okay, person himself come to the OPD with the family member, and he is clearly conscious. So please remember, the consciousness is impaired in delirium, but which is preserved or intact or preserved in the dementia. The course in delirium is what? Fluctuating course, and in it's a gradually progressive in the dementia. That you have to okay. Dementia and delirium, please remember, very important topic, the cardinal feature is what? Impairment of consciousness. Apart from that, there is a transient delusion. Basically, because of impairment of consciousness, delusion आता है जाता है, comes and goes, we call it a transient delusion. There is a sundowning phenomenon. As the sun sets, as the sun downs, person condition get worsen. So in morning and afternoon person remain better, in evening person condition get worse. Okay, sundowning phenomenon. And we have what? Visual hallucination is very common in a delirium. Okay, please remember floccillation, that they are asked. Floccillation, FLOCCA, floccillation, basically picking. Like patient is lying, suppose delirium patient, he will pick on the blanket ki kuch jaise utha raha, something picking, the thread is picking or something, we call it a floccillation. Easy finding, electroencephalogram finding, all delirium patient have what? Slow wave easy, except alcohol withdrawal delirium and benzodiazepine withdrawal delirium. Both delirium have what? Fast wave activity. All delirium have what? Slow wave activity. The treatment of delirium, please remember, that treat the cause. Okay, treat the cause. We give low dose of antipsychotics, haloperidol, to calm down the patient, but the main treatment of delirium is what? Treat the cause. Benzodiazepines are contraindicated in delirium except alcohol and benzodiazepine withdrawal delirium, where the drug of choice is only benzodiazepine, otherwise benzodiazepine is contraindicated. Dementia is another important topic they are targeting again and again. So briefly I will tell you. Okay, it's a major neurocognitive disorder. Now we in DSM-5 and ICD-11 we count it in a major neurocognitive disorder. Okay, we have early onset dementia, and we have late onset. Late means more than 65, early onset means less than 65. Okay, early onset, late onset. What are the genes? Amyloid precursor protein, chromosome 21, amyloid precursor protein, presenilin 1, chromosome 14, presenilin 2, chromosome 1. Okay, and late onset we have chromosome 19 is what? Apoegene. Apoegene basically is responsible for cholesterol metabolism. We have mutation, usually the apo, you know, E2 is more than E3 than E4. This is a normal variant of apoegene. After mutation, E4 become more than E2. That is responsible for dysregulation of cholesterol metabolism and ultimately neurodegenerative changes. Okay, so chromosome 19 apoegene, and we have ubiquitin, chromosome 9. Ubiquitin is basically responsible for protein metabolism. When we have a mutation, we don't have a protein metabolism, abnormal protein also get accumulated, or that is also ultimately responsible for degenerative change. So ubiquitin chromosome 9, the cholesterol, the apoegene chromosome 19, APP chromosome 21, presenilin 1 14, presenilin 2 chromosome 1. This is genetic they are asking. Okay, the macropathology, macropathology, what happened? We have a diffuse cerebral atrophy. We have a diffuse cerebral atrophy. Okay, in diffuse cerebral atrophy, and we have widening of sulci and enlargement of third and fourth ventricle. Okay, fourth ventricle. Okay, in micropathology, that is very important. We do the autopsy, we make a slide, we see under microscope, and what we see, we have beta amyloid plaque. Dementia is very important topic, and we have what? Neurofibrillary tangles. Okay, I hope we will discuss it little bit. It will be helpful. Correct? Yeah. Yes, very true, Bhagavi. The remote memory is intact. Yeah, we have immediate and recent memory deficit. Remote memory remain intact. In micropathology in dementia, beta amyloid plaque, and neurofibrillary tangle. Beta amyloid plaque is an extracellular finding. Neurofibrillary tangle is a intracellular. Okay, beta amyloid plaque we have in all our brain area, including cerebellum. Neurofibrillary tangle that is not found in cerebellum. That is very important. Okay, so neurofibrillary tangle we don't have in a cerebellum, and except cerebellum we have neurofibrillary tangle everywhere. Beta amyloid plaque we also have in a cerebellum as well. Okay, extracellular beta amyloid, intracellular neurofibrillary tangle. Yeah, neurofibrillary tangle basically it tells about the amount of neurofibrillary tangles. Basically tells about the severity and duration of dementia. That is very important. So amount of neurofibrillary tangle tells about the severity and duration of dementia. Correct? Yeah. We have cortical dementia and we have subcortical dementia. Many times they are asking this cortical and subcortical. The Alzheimer disease, Pick disease, frontotemporal dementia, and Creutzfeldt Jacob. Okay, so Alzheimer disease is the most common type of dementia, roughly 50%. Pick disease, another name is, we call it a what? Frontal lobe syndrome. Frontal lobe syndrome and frontotemporal and Creutzfeldt. These are the cortical dementia, and we have subcortical. Subcorticals are what? We have Parkinson disease. Parkinson disease. We have Wilson disease. We have Huntington's chorea. Okay, we have HIV dementia. Okay, we have multiple sclerosis. So Parkinson, Wilson, Huntington's chorea, HIV, multiple sclerosis. Okay, yeah. Normal pressure hydrocephalus. Normal pressure hydrocephalus. Supranuclear palsy. So supranuclear, any basal ganglia degeneration is what? The subcortical. And we have third is what? We have mixed dementia. Mixed dementia. Mixed dementia, we have vascular dementia, we have Lewy body dementia, okay, dementia, and we have neurosyphilis. Neurosyphilis. Okay, these are the mixed. Most common type of is what? Alzheimer disease. Okay, this area also they ask. Many other, briefly I we can't go the through, thoroughly through the topic, but yes, donepezil is a most preferred drug we use, most preferred drug we use. Okay, and the tecrine we don't use because of hepatotoxicity. Yeah, memantine we use in a moderate to severe dementia. Moderate to severe dementia. Please remember, we have MMSC, mini mental state examination. Basically, why we use the MMSC? To assess the cognitive function. Okay, we in MMSC, what we assess? We assess the language, we assess the orientation. Okay, we assess immediate registration, we assess the recall, we assess the attention and concentration. Okay, attention and concentration. Please remember that we have 10 number of orientation, 9 number of language, 3 number of immediate registration and recall, and 5 number we have what? Attention and concentration. That also they can ask. So we have total 30 point score in MMSC. Okay, maximum score is 30. Okay, so that also they can ask, that which as a maximum score. It is orientation, it is not language, it's a orientation. Okay, yeah, orientation, correct. Yeah. Thank you. Thank you so much. Yeah, so out of 30 we have 25 or more. It's a normal score. 21 to 24, 10 to 20, and less than 10. We say it's a mild dementia. We have moderate dementia, and we have severe dementia. Okay, so mild, moderate, and severe dementia. Thank you, our FMT guru sir. Okay, mild, moderate, and severe. Yeah, so the next we'll go with the MCQ, because time also we have. This is my problem, that I always once start topic, I just want to tell everything. Okay, so in this, the question number 13 answer will be acute onset and level of consciousness. So in delirium is acute onset and the consciousness will be impaired. A 42-year-old male came to the psychiatry outpatient department with a history of repetitive thoughts about his hands being dirty always, even though they are not. He also knew that these were in his thoughts only, and which gave him discomfort, and so he preferred to wash his hand again repetitively. This is a disorder I mentioned. So we have disorder of, okay, so I will just tell you that we have a disorder of flow, have form, we have this possession, we have what, content. Here many students they get confused, so please remember, till the content we always describe what, delusion. Please remember this, the delusion is a disorder of thought. So the thought of content, the thought content, under thought content, what we describe, dear students, delusion. Please remember. Thought possession, already I mentioned that thought possession we already discussed. What we describe, obsession, thought insertion, thought withdrawal, thought broadcasting, already we discussed. Flow, we have flow, or we say stream of thought. Flow or stream of thought, which disorder we describe here, flight of ideas. Flight of ideas we see in mania. Okay, prolixity we see in what, hypomania. Okay, prolixity, we have thought block, suddenly stoppage of thought. We have perseveration. What is perseveration? Perseveration is repeating words or sentence beyond a point of relevance. Suppose I am asking, what's your name? You are saying Amit. What's your father name? Amit. What's your brother name? Amit. So one MCQ or one question, there was a relevant answer, that what's your name? You have told Amit, right answer. Beyond that it lost the relevance. So perseveration is what, repetition of words or sentences beyond the point of relevance. This is perseveration. It's a sign of organic disorder. Sign of organic disorder. The sign of organicity. If the person is having a perseveration, then there is very high chance that there is a organicity or organic disorder, like visual hallucination. So thought block, perseveration, prolixity, flight of idea, we have flow or stream of thought, and we have formal thought disorder. In formal thought disorder we describe what, we describe derailment. We describe derailment, person like from one topic to another topic to another topic and never comes back. We have tangentiality, person starts from the original topic, goes to the another topic, and then in between comes to the original topic. Suppose person you asking, tell me about Delhi. The patient started from the Delhi, then he go to the another topic, then another, and then intermittently he comes back. This is what, tangential. So we have a derailment, we have a tangentiality, we have a circumstantiality, we have circumstantiality. Okay, this is also formal thought disorder. We have verbageration. So circumstantiality, person you ask them, okay please, I'm in Delhi, I have to go to the airport, how to go airport. Person will tell how to go to the airport, so he reaches to the goal, but he gives unnecessary tedious detail which is not required. This is circumstantial. Verbigeration is what, word salad. It's like a word salad. Person is the most, you can say it's the most severe formal thought disorder. Person just keep repeating the unnecessary words, nonsense words again and again. Verbigeration. Okay, yeah, so these are the some formal thought. There are few more, but just remember. So formal thought disorder, these are the disorder comes under formal thought disorder. The flow or stream, flight of idea, it's important. Usually the student they don't have a good hold on this topic, and we have a thought content, we have a delusion and thought position. So delusion comes under disorder of thought content, and obsession comes under thought possession. There the students get confused. Okay, so question number 14, answer is C for Calcutta. Least sexual side effect can be associated with the following antidepressant. In this also MCQ they are again and again asking, so I will tell you. Just see, first is what? TCA is the most common, then the SSRI, okay, then the Wallah vaccine, then the miltazapine, and then the bupropion. That you have to remember. Again and again they are asking in many ways. So maximum with TCA, least with bupropion. So I told you in the ascending order. So how they ask, accordingly you see the MCQ are the options. Okay, so maximum with the TCA, then the SSRI, then the Wallah vaccine, then the miltazapine, then the bupropion. From the the descending order, you want to go least with the bupropion, then the miltazapine, then the Wallah vaccine, then the SSRI, then the TCA. Okay, so that they can ask. So in this question number 15 is answer. That MCQ they are asking again and again, so you have to be very careful. Okay, clear? Okay, the next MCQ is okay. Next is next is question number 15. Answer will be mirtazapine. B for Bombay, least sexual side effect. And if bupropion would have been given in answer, then bupropion would have been the answer. Which among the following condition present with the subcortical dementia? Subcortical dementias are already I mentioned: Parkinson disease, Wilson disease, Huntington. Pick disease is not a subcortical, it's a cortical. So answer will be B for Bombay. B for Bombay. Question number 17. In a patient with schizophrenia, all of the following are good prognostic factor except. So we have a good prognostic factor and we have a poor prognostic factor. So good prognostic factor. Good prognostic factors are acute onset is a good prognostic factor. Okay, no family history of schizophrenia is a good prognostic factor. Positive symptoms like delusions and hallucination is a good prognostic factor. Okay, late onset is a good prognostic factor. Okay, personal or family history of depression or mood disorder is a good prognostic factor. Okay, what does that mean? See, usually a normal person will think that there is a schizophrenia, now there is a depression, so there are two disorders, so prognosis should be poor. No, basically there is a apart from schizophrenia, person if having a depression, it means what? Person emotions are intact after schizophrenic symptom. If the person going into the depression, it tells that his or her emotions are preserved. So going into depression is a good prognostic factor. But suppose person who is suffering from severe schizophrenia and he doesn't know what to do, what is goal, future mein kya hona hai, he doesn't know anything, so he will not go into the depression because he will not have any worry about the future. So schizophrenia patient going into the depression tells that his or her emotions are preserved, so it's a good prognostic factor. Okay, so acute onset, no family history, positive symptom, late onset, personal or family history of depression is a good prognostic factor. So and opposite will be the poor prognostic factor. So associated with the depression is a good prognostic factor. Insidious onset of symptom, yes, gradual onset. Okay, a gradual onset will be what? The poor. Positive symptom is good, late onset is good. So insidious onset is a poor prognostic factor because acute onset is a good prognostic factor. Okay, so question number 17, answer will be B for Bombay. B for Bombay. Question number 18. A patient who was diagnosed to have a psychosis had presented with the voluntary purposeless movement. One day he was observed to stand still in the IP ward, the inside the ward, and along with the negativism and also vaccine flexibility. The most appropriate medical management will be. So basically, person is having what? Person is having a catatonia. Catatonia. In catatonia, dear friends, please remember, catatonia is a, like before we were counting under the another psychiatric disorder in ICD. First time ICD 11, the separate diagnosis. Okay, the separate diagnosis, and we have catatonia due to catatonia due to mental disorder, and catatonia due to substance induced disorder. Okay, so we have a separate diagnosis. We have many signs and symptoms in catatonia: echolalia, repetition of words, echopraxia, repetition of action, vaccine flexibility. We have negativism, we have Gegenhalten. Okay, so these symptoms you know. Only just remember the treatment. Yes, we give IV lorazepam. Although the mechanism of catatonia is not very clear, some say there is a glutamate hypothesis, some say there is a GABA, hypothesis. But yes, lorazepam has a very good response. The catatonia patient has a very good response with the lorazepam. Okay, if lorazepam is not working, then you will go for the ECT, electroconvulsive therapy. So theoretically speaking, lorazepam, then the ECT. Clinically speaking, if the patient is having a very severe condition, then you better go for the ECT directly, because lorazepam is a basically anti-epileptic drug. If you give lorazepam, there will be the ECT. By giving the ECT, basically we induce the what? Seizure. So if you give lorazepam, it's anti-epileptic, it will increase the threshold for the seizure, and it will be difficult to induce the seizure by the ECT. So if you want to give ECT, then don't go for the lorazepam. So theoretically speaking, lorazepam, then the ECT. Clinically, you have to see the condition of the patient and you have to decide accordingly. Okay. So in the lorazepam, in this MCQ, the lorazepam will be the answer A. Okay, in ECT, they can ask ECT, few MCQ about the ECT. ECT is a what? The Sarleti and Bini has given the ECT. Okay, we have unmodified ECT and we have a modified ECT. Modified ECT means ECT with the under the cover of anesthesia, and in anesthesia we give what? Succinyl choline. Okay, it's a muscle relaxant. Okay, succinyl choline. Yeah, and we give also the methoxytol is a agent of choice. So methoxytol is an anesthetic agent of choice in ECT. Okay, if they ask you the succinyl choline, it's a muscle, we use as a muscle relaxant. In according to current the mental health, our mental health care act bill, you can't give ECT, to the minor means less than 18 years of age. But you think if ECT is the only treatment of choice, then you need the consent of 2 psychiatrists. Okay, consent of 2 psychiatrists. But otherwise ECT is, you can't give. The unmodified ECT or the direct ECT without anesthesia is banned now in India. But if you can't give the minor to the ECT to the minor in pregnancy. ECT in pregnancy is a safest procedure. Please remember, ECT is a safest procedure in the pregnancy. So this is question number 18. Answer is lorazepam for the catatonia. Question number 19. The feature of selective mutism were found in an 11-year-old child. The most probable disorder in this child will be. Yeah. So selective mutism, it's a like new category. Selective mutism, we have selective mutism, a person is not able to speak in one situation. So in a one particular situation, the child is not able to speak, but he able to speak fluently in another situation. So he is able to speak the fluently in another situation, but he is not able to speak in a one particular situation. We call it a selective mutism. Selective mutism, it's a like new diagnostic entity we have now in under anxiety disorder. So it's a childhood anxiety disorder, selective mutism. And we also use the one another diagnosis, separation anxiety disorder. So we have separation anxiety disorder, we have selective mutism. In separation anxiety disorder, the child having a the excessive anxiety or worries to from the detachment of the attached figure. So major attached figure like mother, the child having a very excessive this anxiety to get separated from the major attachment figure. This is a separation anxiety disorder. And selective mutism is a new diagnostic entity we describe now under the anxiety disorder in a childhood anxiety disorder. So please remember, question number 19 answer will be C for Calcutta. A 7-year-old male child was brought to the pediatric OPD with a history of the bedwetting for the last 1 year, frequency of 2 times in a week. After detailed evaluation, organic causes have been ruled out. Which among the following would be the initial treatment plan in the child? Okay, so basically it's a what we have, what nocturnal aneurysm. So nocturnal aneurysm, what is a cutoff age of nocturnal aneurysm? 5 years. First you have to remember 5 year. Okay, we have a primary and we have a secondary nocturnal. Primary means there is a never person had a history of dry bed, always bedwetting. Secondary, the 6 to 12 months he had a history of dry bed, and then again there is a bedwetting. So secondary, due to some emotional trauma, maybe there is a another sibling came into the picture, and the family member started devoting more emotions to that sibling. Then the child get disturbed that the all love I was getting, and then why suddenly it happened, or sometime due to some other reasons. So secondary nocturnal aneurysm. So first you have to remember it's a 5 year, it's not 6 year. Now the cutoff age is 5 years. Second, what is the first step in a nocturnal? This is a they love AIMS people love this MCQ, so please be very careful about again and again, maybe 20 times in last 10 years they have asked this MCQ. So first step is what? Rule out organism. Rule out organism. Rule out organicity. What we do? We do the ultrasound, we do the X-ray, KUB, kidney ureter, both. So you just ruled out the organicity. Once you ruled out the organicity, the second step is what? We have reassurance. You reassure the mother that don't worry, wait for the 6 to 12 months, things will be fine. If reassurance is not working, what is the third step? The third step is what? Treatment. And if they ask you, the treatment of choice is what? We have the bell and pad therapy. Pad therapy. We basically, child wear the diaper, there is a bell, and basically when he passes the urine, there is a circuit, and because of that the bell get buzzer. And this is a we have this classical conditioning of the bell and pad therapy is a treatment of choice. If they ask you the drug of choice, then your answer will be desmopressin. Okay, desmopressin. Before it was imipramine, now we give desmopressin. Initially we were giving the the spray of desmopressin, but the serious side effect is what? Nasal bleeding. Nasal bleeding was the serious side effect. So we started giving the oral, the oral medication. But desmopressin is a drug of choice. The treatment of choice is a bell and pad therapy. So which step they are going to ask? Be very very careful about it. So the Bell and PED based classical conditioning, pharmacotherapy with imipramine, no. Bladder training with reward or delay micturition, no. Psychodynamic, of course not. So answer will be A for apple. Okay, so that you have to remember. Imipramine before we were giving, but not now. Yes, with toilet training we give to the child, but no, the main treatment is what? Bell and PED therapy. One MCQ we left here, and that MCQ was, yeah, match the following description related to the psychiatry condition correctly. Okay, so this is the first is the burnout. Person is having a getting symptom, so like exhaustion at workplace that get relieved when not on duty. Yes, that is burnout. Overworked is what? Exceeding one's ability to workplace, this is overworked. Suicide, person is having either relationship fallout is a risk factor, more with the substance abuse and female physician. And the depression is person is having a difficult to diagnose because of pride. Sometimes people hide, they think that how I can be, so people think that depression is a weakness, so they basically don't want to express the symptoms. So in this, the basically answer will be 1 will be A, the 2 will be the D, the 3 will be B, and 4 will be C. So the answer will be if A for apple. So question number 7, answer will be A for apple. Okay, okay, yeah, hello, yeah. So I hope you enjoy this. Apart from that, this sexual disorder, again and again they are we have, the test was just briefly I will tell you the sex, the sexual cycle. We have what? The first is what? Desire. Second is what? Excitement. Third we have what? Orgasm phase. And fourth is what? Resolution. Okay, for desire we have excitement. The erectile dysfunction is a disorder of excitement. Orgasm is we have what? Premature ejaculation. So that please remember. In the recent PG, the NEET PG exam also, they ask that we have a master and Johnson therapy. In master and Johnson therapy, the couple therapy, we have what? Sunset focus, and we have what? Quiz technique. Sunset focus we use for erectile dysfunction. Quiz technique we use for what? Premature ejaculation. Okay, premature ejaculation. And this in premature ejaculation also we use like paroxetine. We use the side effect of paroxetine. Also we use what? Depoxetine. We use depoxetine. Okay, yeah, depoxetine. In erectile dysfunction we have, most common is what? We have a psychological or psychogenic. Most common erectile dysfunction is psychogenic or psychological. Okay, so this is the, we can't cover everything, but you have exam on 7th of May. Still there is a time. As a your faculty, as a psychiatrist, I will advise you in last today is 21st, so 7th you have exam, so hardly you have 10-15 days. So 2-3 things, my humble request, now don't read the new thing. Okay, try to revise your if you have a short notes as soon as as much as possible. Last 3-4 years question bank is a crucial in every exam, so if you have covered them nicely, try to revise them properly. And the many students have this habit to like they become nocturnal, they don't sleep in night, and in morning then they have a difficulty. So now, apart from your knowledge, the more important is your health now, your mental fitness, and how much knowledge you can use in examination hall. So please be very careful that don't now if you have a disturbed sleep wake cycle, get proper sleep wake cycle. That is more important. Sleep at least 11:30 on night, get up, and then during daytime try to study, and don't take food outside or something. Now this infection, and that is also very important. So apart from your study, your health, your sleep pattern, these things are become more important. You in one day you can't come in the competition, you can't go out from the competition. So these 10-15 days will not decide much. Just be very careful that if you are really studied nicely, then you can get into this exam. So don't read new things, don't be in a very like, okay, I have to do, I have to do. Don't stimulate yourself, be calm, be cool. Try to revise your the basic and minor subjects more. The basic and minor subject is a backbone of any exam. And sleep pattern, your mental fitness, that also you please take care about it. Okay, that is all from my side. If you have any apart from that, you always, now we have our app is launched. We all are there together 19 and with our team worker. So any queries you have, we have a telegram also. Soon you will get the notes also. We are working very hard to get them out as soon as possible. So this is a platform where you will get everything, the MCQ, the notes, and have collective teamwork is there. Please join more and more and give you know this have a this your education of journey and journey with us. If you want to particular, we have telegram also. If you have any query, you can ask me in a particular sending message also. If you have any, nowadays as a psychiatrist, I will request you, life is more important, life is more beautiful. Exam will come and go, so don't be so stressful and don't be so कि अब नहीं हुआ तो क्या हुआ, कोई बात नहीं, नहीं हुआ तो सेकंड एग्जाम आएगी, बट लाइफ बार बार नहीं आएगी. सो बी वेरी केयरफुल अबाउट कि लाइफ इज़ मोर इम्पोर्टेंट. एग्जाम आती हैं जाती हैं, इट्स अ पार्ट ऑफ लाइफ, इट्स नॉट होल लाइफ. ओके, so God bless you, best of luck, and I hope you will do better. And after INI-CET, try to the MCQs, try to share with me, and we'll see after INI-CET what they have. Usually in psychiatry 8 to 10 MCQs they are asking. Let's see what they will ask in this. Okay, this time. Okay, best of luck. Bye bye guys, thank you.